Hello, this presentation is by Dorothy Moore. I'm talking about Parkinson's disease dementia, and I'm going to give you an overview of the pharmacological management of this disease syndrome. We're going to talk about the disease, Parkinson's disease dementia, who gets it, what the symptoms are, review the neurotransmitters that are so important in understanding this disease. Specifically, I'm going to talk about Aricept, Excelon, Seroquel, Clozaril, Nuplazid, and Melatonin. Parkinson's disease is the second most common neurodegenerative disease in the country. It affects upwards of 2 million people. The average onset age is over 60. It affects more men than women. Genetics does play a role. So does environmental exposure to pesticides, herbicides, heavy metals. So we think of Agent Orange as being a key herbicide implicated in Parkinson's. Unfortunately, so many Vietnam vets were exposed to Agent Orange during the 1970s, so the Veterans Administration has a lot of studies, good studies on Parkinson's because they have so many Parkinson's patients. Head injury, traumatic brain injury is also tied to Parkinson's. Again, the VA has done studies on that, but we think of Muhammad Ali as having Parkinson's disease because of his many head injuries, likely. And then viruses are another causative factor, probably hepatitis C for one. Michael J. Fox is thought to have been part of a virus cluster. He worked with a group of people who, many of whom have Parkinson's disease, which is statistically unusual, and the common factor seems to be a virus they all had. So we think of motor difficulties when we think of Parkinson's, specifically shaking or tremor, the pill rolling, stiffness, what we call the Parkinsonian mask, slow movement or bradykinesia, difficulty with balance and coordination. But these are actually late signs of a disease process that takes a decade or more to develop. The early signs of Parkinson's are restless leg syndrome, REM sleep disturbance. Pay attention to that because it's important again in the dementia. Amnosia, the loss of smell, is an early sign of Parkinson's, as is constipation. So these don't necessarily mean you're going to get Parkinson's, but they're key predictors. Here's the pathophysiology of Parkinson's disease. It starts probably because of the factors we talked about with the destruction of the dopaminergic neuronal cells in the substantia nigra of the brain's basal ganglia. In other words, the cells that produce dopamine start to die off, and this depletes a person's dopamine stores and impairs their ability to move. And we get these four features: the tremors, the rigidity, the bradykinesia, and the postural changes. Here's the brain and the pathway, the dopaminergic pathway they call it, that is affected by Parkinson's disease. So pay attention to that substantia nigra, which is where the disease process starts. And here's a simplified picture of a neuron, one that's producing a lot of dopamine and one that's not producing very much. And of course, the second one is the Parkinson's patient. So it is not just a movement disorder, as I said, and the Parkinson's disease dementia is an example of the non-motor effects of Parkinson's disease. The dementia occurs in about upwards of 40% of Parkinson's patients. Age of onset of Parkinson's disease, the REM behavior sleep problem, and other factors seem to be predictive of who's going to get the dementia. So in order to get the diagnosis of Parkinson's disease dementia, you have to have Parkinson's disease for many years before you begin to have dementia. The dementia is characterized by delusions, hallucinations, psychosis, and these symptoms fluctuate. There are good days and bad days. On autopsy, we find Lewy bodies in the person's brain. Lewy bodies are a cellular collections of something called alpha-synuclein and ubiquitin. These are two proteins that occur at the cellular level from the destruction of the dopamine-producing cells. So I guess I would think of them as big glad trash bags that the brain stuffs all this protein into in order to be tidy, but these trash bags begin to be an impediment to the neuronal pathway, and that causes a movement disorder. So on autopsy again at the basal ganglia near the olfactory bulb, you're going to see a lot of these Lewy bodies, because remember the olfactory bulb is in the brain stem. It's a primitive, one of our primitive, most primitive senses. So more symptoms, we see a change in personality. The person becomes paranoid. They're often depressed and anxious, and they have bradyphrenia. And the opposite of schizophrenia in a way. They have very slow thought. They might reach the right conclusion, but it takes so long for them to get there. As I said, the symptoms fluctuate, good days, bad days. They're having trouble with retrieving memories. They can still recognize faces, people, places, but they have trouble with retrieval. This is unlike Alzheimer's disease, where the person actually eventually can't recognize their loved ones. The person with Parkinson's disease dementia also has trouble with executive function. They can't follow instructions, can't complete multi-step tasks. They have attention impairment, and they have visual spatial difficulties, so they're at increased risk for falls. They might not be able to navigate their way out of a crowded room with a lot of furniture. So a little bit more about the visual hallucinations. It doesn't look like it's spelled right. In Parkinson's disease dementia, many patients will tell you they're not hallucinating for years while they actually are hallucinating, because they're aware of their hallucinations. They are embarrassed about them. They want to hide this from people, but they are having these hallucinations. It's thought to be due to a neurotransmitter acetylcholine deficiency and too much dopamine. And the visual hallucinations are often about animals, children, or objects, and they often have this tactile component to them. So again, Alzheimer's disease is different than Parkinson's disease. The two can occur together, but they're very different processes. So the drugs for one are not the same as the drugs for the other. That is the takeaway message here. Parkinson's disease dementia is this destruction of the dopamine-producing neurons and the accumulation of Lewy bodies that occurs along the axons. And what happens is this dopamine acetylcholine imbalance starts to occur in the basal ganglia. So here we see Alzheimer's versus Parkinson's. The Alzheimer's person has these beta amyloid plaques. The Lewy bodies are associated with the Parkinson's disease. So enough said about that, but just know that one drug doesn't really work forever for both types of patients. So I want to talk a little bit about neurotransmitters, because these are key to treating the Parkinson's disease dementia patient. So we have dopamine, which is used for voluntary movement and balance and coordination. It is what amplifies or turns up our motor activity, but too much dopamine is also linked to psychosis. Acetylcholine is a neurotransmitter that's used both in the parasympathetic nervous system and the central nervous system, so it turns down motor activity. And these two have to be in balance for proper movement and thought. A little bit more about acetylcholine. It controls memory, excitability, arousal. So Parkinson's patients who have too much acetylcholine often become gamblers, they become hypersexual, they go on shopping sprees, all these weird personality changes that you would never expect from the person. So cholinesterase is the enzyme that breaks down acetylcholine. Our cholinesterase inhibitors slow or prevent the breakdown of acetylcholine, hence increasing the person's ability to concentrate. So a good amount of acetylcholine is good for a person's memory. Too much of it causes peripheral nervous problems where the person is having exaggerated spasms, jerkiness, all these kinds of things. So for first-line defense, we do reach, first-line treatment, we do reach for the cholinesterase inhibitors in treating dementia. So as I said, we're going to use the cholinesterase inhibitors, Aricept and Excelon particularly, can improve cognitive function in the Parkinson's patient early on. Anticholinergic drugs, however, often exaggerate their symptoms. So the tricyclic antidepressants, the antiemetics, the antihistamines, the antipsychotics, not good for the Parkinson's disease patient. So you have a lot of treatment dilemmas with Parkinson's disease dementia. Too much dopamine, which is, of course, what the Parkinson's patient is taking. They're taking Sinemet usually, can worsen or trigger psychotic symptoms. We have to be really careful with this and watch how much dopamine they're getting, particularly when they get psychotic, and I'll talk about that a little bit later. So we want to avoid using the typical antipsychotics in Parkinson's patients because they block dopamine. They might be okay for the Alzheimer's patient, but not good for the Parkinson's patient. Instead, we use atypicals, Seroquel and Clozaril. So first I'm going to talk about treating just the dementia symptoms, and for that we use cholinesterase inhibitors. Aricept is the first drug I'm going to talk about. Mild to moderate benefit early on, but it has a lot of bad side effects: nausea, loss of appetite, trouble sleeping, and depression. At a certain point in the dementia progression, these cholinesterase inhibitors have to be discontinued, though, because they're getting too much acetylcholine and it starts to exaggerate their Parkinson's symptoms. So what's recommended by the experts is to use Aricept and Excelon until the side effects become intolerable. Aricept has some major drug interactions, particularly with Wellbutrin, Omnipaque, Tramadol. These have an increased risk of seizures for the patient. The other cholinesterase inhibitor commonly used is Excelon. It comes also in a patch, which has fewer GI side effects, so patients like that. Again, mild to moderate benefit early on. It can also help decrease hallucinations as well as help with the executive function and memory issues. It interacts poorly with the same list of drugs, the Wellbutrin, the Ultram, the Omnipaque. Also should not be taken with beta blockers, DIG, amiodarone, calcium channel blockers, because it can actually cause AV block, bradycardia, hypotension. And as a note, do not use with Reglan because of the risk of EPS symptoms. So treating psychosis, I think I alluded to that earlier, but you want to reduce the dopaminergic medications because it's the too much dopamine, we think, that's causing the hallucinations. You want to eliminate the contributory meds, such as the anticholinergics and the benzos if they're on any, and then, of course, rule out metabolic causes. So it's difficult to tease out if a person's hallucinations, psychosis are drug-induced or drug-related, disease-related, since the disease process makes the patient paranoid and hallucinating. So what you want to do is rule out causes and then stop medications in order of potency, with the levodopa being the last one, the Sinemet being the last one that you remove. So if you do need to treat the patient, if they're really at risk of hurting themselves or others, you will use these atypicals, Seroquel or Clozaril. Seroquel is the best tolerated. But know that all antipsychotics are associated with death in Parkinson's disease dementia patients. And this is a reiteration of the treatment algorithm for the Parkinson's disease dementia patient, and the dosing for Seroquel and Clozapine, and this new drug, Pimavanserin, that we're going to talk about. And never use Namenda. While it's beneficial to Alzheimer's patients, it can actually worsen hallucinations and increase the likelihood of death. So specifically talking about Seroquel, it is an atypical antipsychotic. Side effects are constipation, weakness, dizziness, dry mouth. Caution with amiodarone, it can cause QT prolongation. It does or can increase suicidal ideation, especially when started. The person gets more energy, they are thinking a little clearer, and hence a risk of death for the elderly, particularly. And Clozapine, also an atypical antipsychotic. It's really a dirty drug, if you want my opinion. It's known for causing agranulocytosis, so when it started, it's recommended that the patient be monitored weekly for the first 6 months for neutropenia, so blood draws on a weekly basis. It can cause myocarditis. It can also lower the patient's seizure threshold, can cause high blood sugar, hyperlipidemia, and has a black box warning for sudden cardiac death. Side effects, more side effects: weight gain, insulin resistance, increased risk for pulmonary embolism, urinary incontinence, constipation, increased sedation, and increased EPS, like tardive dyskinesia. It interacts adversely with Abilify, benzos, SSRIs, and Geodon. This new drug, Nuplazid or Pimavanserin, was just approved this summer. It's billed as the first antipsychotic specifically for a neurological disease. It's, get this, a non-dopaminergic atypical antipsychotic. It's a reverse agonist of the 5-HTA receptor, which apparently is the same target receptor that's targeted by LSD. So I guess if you can block that receptor, you're blocking the ability to hallucinate. Since it's working on a different pathway, it's not associated with the worsening of motor symptoms or other problems that we see when we're dealing with dopamine. Its long-term safety and efficacy have not been established. I did read a paper about the phase 3 clinical trial, which used 199 patients and ran over a course of 6 weeks. So to me, that's not a lot of data. It's believed to have a lower side effect profile than other antipsychotics. It can cause QT prolongation with certain medications, for example, clarithromycin, Haldol, amiodarone, Geodon. A final medication I want to discuss is melatonin. As you may know by now, sleep disorders are a major feature of Parkinson's disease dementia. The belief is that disease process begins in the substantia nigra, which is also where melatonin is produced. The substantia nigra is called that because it's dark, because there's melatonin there. Melatonin is dark. Melatonin regulates our sleep-wake cycle, and so it's shown that giving patients this supplement is useful in regulating their sleep. Here's a pathway that is showing that it possibly could even be slowing the progression of Parkinson's disease if the patient gets supplemental melatonin. And that's it. So here's some websites, good websites about Parkinson's disease.